Do you know about the silent killer that can destroy a tooth from within? Most of the time, it causes no symptoms and is discovered only by chance on a routine radiograph. That's internal resorption. It starts with long-standing inflammation and bacterial invasion of the pulp. This damages the odontoblast layer, leading to the formation of dentinoclast from undifferentiated mesenchymal cells that begin to resorb dentine from inside of the root canal wall. What causes it? Sometimes we don't know the cause at all. Like it can be idiopathic, but it also can be associated with trauma, deep caries, excessive heat during restorations, and even orthodontic treatment. Internal resorption is rare in permanent teeth, but when it does occur, it's often seen in traumatized incisors or mandibular molars affected by caries. In primary teeth, it can occur as a part of normal resorption process, or it also has been linked with the use of calcium hydroxide. Coming to the types, according to Anderson, there are two types: inflammatory internal resorption, where dentine is resorbed and granulation tissue forms, while in the replacement internal resorption, the lost dentine is replaced by bone or cementum like tissue. Another classification by Linkskog has three types: trauma induced, infection induced, and invasive cervical hyperplastic resorption. What are the signs and symptoms? Like I said earlier, there aren't any. That's why it's often picked up accidentally on an X-ray. Symptoms may appear only when the lesion perforates or become exposed to oral fluids. Internal resorption can occur anywhere in the tooth, but it's most commonly seen in the cervical region. When enough dentine is lost and the pink granulation tissue underneath can show through the enamel, giving the tooth a pink appearance. This is why it's also called the pink tooth of mummery. On an X-ray, internal resorption appear as round or oval radiolucency. It creates a characteristic ballooning out appearance of the root canal with smooth margins and distorted canal outline. Now, how do we manage this? Treatment entirely depends upon the type, extent, and the prognosis of the lesion. So it varies from case to case. If the resorption has perforated extensively and the tooth cannot be restored, extraction is the only option. That's why early diagnosis is so important. For infected or inflamed cases, RCT with an intracanal medicament for at least 2 weeks followed by obturation is done. This type is generally the easiest to manage. Coming to the trauma-induced cases, radiographic monitoring with a wait and watch approach is done. If infection develops, proceed with an RCT. For replacement resorption, emdogain, which is primarily made of amylogenins, is applied to the resorbed area to stimulate new cementum, PDL, and alveolar bone formation. The replacement and invasive types are much harder to predict and control. For invasive resorption, 90% trichloroacetic acid is applied to chemically cauterize and remove the invasive granulation tissue. RCT is done if needed, followed by intercanal dressing and a GIC restoration. Regular follow-up is essential since invasive cervical lesions have real chance of recurrence. For repair and obturation, materials such as MTA, thermoplasticized GP, super EBA, zinc oxide eugenol, and zinc acetate cement may be used. The key message is simple. Internal resorption is often silent, but early diagnosis and timely treatment can help save the tooth. Thank you for watching. If you found this video helpful, make sure to like and subscribe to my channel.